Thank you for having me here. I'm excited to join the class and see how many students are interested in psychedelic therapy and psychedelic science. So as Dylan said, I'm a clinical psychologist based in Oakland. My time is really split between doing clinical work and research involving psychedelics. In my clinical work, I've spent many years working in psychiatric care settings, working particularly with difficult to treat conditions like schizophrenia, mood disorders, anxiety disorders, addictions, and especially trauma. And one of the major things that I noticed working in these programs was the difficulty that people tended to have with the traditional treatments for many of these conditions. And particularly when it comes to trauma and PTSD, the traditional therapies that we have are seriously lacking and often can be experienced as very difficult and sometimes can even make things worse before they even get better. So this is one of the things that led me to being interested in what alternative treatments might be available and led me to researching and exploring psychedelic therapies as options. So since about 2012, I've been leading and consulting on a number of qualitative studies in the psychedelic sciences. We'll talk more about what this means, but ultimately, this entails interviewing participants after they go through these MDMA-assisted psychotherapy trials to better understand their experience in the treatment and look into how the therapy works and to know more about how we can make it better. So I've also worked with MDMA treatment in a number of other positions, including as an adherence rater for the active phase 3 clinical trials. And so this phase 3 trial is actually the final FDA clinical trial needed before the FDA can approve MDMA as a legal and accessible therapy. So as an adherence rater, I oversee therapy sessions taking place and provide feedback to the therapists and make sure that the therapy is taking place according to the therapy manual. So between the qualitative work where I get to interview dozens of participants going through these treatments and my role as an adherence rater where I watch hundreds of hours of the therapy taking place, I've developed kind of a unique view into looking at how this therapy works and how it's experienced by participants. So while this talk does have a focus on qualitative research and what it means for the psychedelic sciences, I understand that there's not yet been a class that's focused on MDMA-assisted psychotherapy in depth and what it means as a treatment. So for that reason, I also want to use this as an opportunity to better understand what MDMA-assisted psychotherapy is and how it is employed. So through this class, we'll be focusing on what is MDMA-assisted psychotherapy? Why could it be suitable as a treatment for post-traumatic stress disorder? What have we learned about the clinical mechanisms of this treatment? And what is the participant experience? How do we use qualitative research to better explore and understand this treatment? As well as what are the short and long-term outcomes of somebody going through MDMA-assisted psychotherapy? So before we get moving into these areas, I wanted to start with a short description of one participant's experience going through an MDMA-assisted psychotherapy clinical trial that I had worked on. So on the screen right now is a quote from one of our participants who we'll call Jim. And so Jim is a 46-year-old war veteran who participated in one of the phase 2 clinical trials. Like all the participants in these trials, Jim experienced a severe degree of PTSD after returning from war and lived with these symptoms for nearly 20 years. As Jim describes PTSD here, it changed everything in his life. He became very separated from his emotions and felt like he was really barely able to, he was so overwhelmed that he could barely function. Jim also suffered from daily nightmares of things that occurred during the war and when he was awake, he regularly experienced intrusive memories of traumas from his past. These experiences, along with chronic pain issues, led Jim to a life of isolation. Because of his symptoms, he was not able to work, and because of how he was dealing with his symptoms, he had really isolated himself from friends and family, not wanting to expose them to the part of himself that either was removed from his emotions and numb, or the part of himself who was overwhelmed and holding a lot of rage. So like all the participants in these clinical trials, Jim had tried many different treatments for these symptoms and did not find any long-term benefit. He had basically tried every treatment that the VA would throw at him, and for reasons that we'll talk about shortly, he just felt like he was getting worse and worse. Even when he was referred to take part in this clinical trial, he really didn't have much hope for it working. He had pretty much given up on the idea that therapy could help with any of these problems, and he felt that his medications were not really solving anything. However, Jim had some very interesting experiences while in this clinical trial, and his story has actually done a lot to help us understand how this therapy might actually work for people. So in our interview 1 year after Jim completed treatment, he told us that never in my life have I relaxed like I did during this. Maybe like what you would feel in your mommy's tummy or something. Being back in the womb, very safe, very warm. And for me to get where I needed to get within my own mind, I had to relax that way. Jim talked about feeling incredibly relaxed and comfortable while on MDMA in the session, a place of safety that he does not remember having at any point in his life. He talked about how important it was for him to find this place of comfort and safety in order for him to do the work that was needed in this therapy. So talking about his participation in the MDMA session, he says, it's a weird way of your mind showing you your own memories. And then you can relive it. You can feel it. You can see it. You can smell it. But yet you're safely away from it. And you're still thinking in your adult mind, not from a child's mind, not understanding what's going on. This is a hugely important insight that Jim has shared. And this is one that we'll come back to a little bit later. But basically what he's saying is that for the first time since the trauma occurred, he was able to look at these traumatic experiences without the normal resistance of the traumatic effects on his nervous system, and was able to think through these traumatic situations with new insight, self-awareness, and compassion. In the same interview, he told us that it's the one thing that's helped me since 1995. The one thing that I've tried and done that's helped in any kind of way. None of the drugs they gave me, psychology, seeing a psychiatrist. It's the only thing I felt like I got benefit from. Not because it feels good or some kind of high, it just helps. Now, one of the especially interesting things about Jim is that he is the one person from our clinical trial that showed the smallest change in his PTSD scores over the course of the trial. So the way that PTSD symptoms are measured in these trials are with the clinician-administered PTSD score, or also called the CAPS. And so the CAPS is a measure that gives somebody a score of how severe their PTSD symptoms are. And this is thought of as the gold standard in how to measure PTSD symptoms in clinical trials and clinical practice. So while the majority of participants experienced massive reductions in their CAPS scores, many to the point being to below the threshold of having a PTSD diagnosis anymore, Jim's scores indicated that he did not show much change at all in his PTSD symptoms. So based on those scores alone, it would be considered that this treatment was not beneficial for Jim. However, what he told us was that there's improvement in every aspect. I would say there's improvement from every one of my problems I had when I first came here. So while Jim's symptoms scores on the CAPS may not have shown much change from the start of the treatment, Jim expressed changes to many different areas of his life. After this treatment, he reported improvements in how he experiences and understands his emotions rather than dissociating from them. He talked about improvements in his relationships and taking part in his community. He noted that while some of his symptoms may still be present, the way he manages them has changed dramatically. Following the treatment, Jim was able to get off all of his previous medications and was able to continue therapy, feeling like he was actually able to start benefiting from therapy in a way that he never was before. He told us that, not everything was great after the therapy, and that before our interview, he had actually been having a difficult couple months, but he did tell us that he had a new way of dealing with his symptoms and dealing with the things he was going through that he just didn't have before going through this treatment. So the way that we learned these things about Jim was through a qualitative follow-up study where we interviewed participants 1 year after they went through their treatment in this phase 2 clinical trial. And then my team and I analyzed the interviews to better understand the participants' experience from before, during, and after the treatment, and get a sense of why they felt this treatment might have been effective, try to understand what the mechanisms of the therapy might be, and have a chance to make the therapy actually even better. So many of the things I'll be talking about today come from the lessons from these qualitative studies and the time I've taken to watch the therapy take place as an adherence rater. But also it's come from the amazing work of the therapists and clinicians and researchers that have worked on this treatment for many years. I also want to note that at times today I'll be talking about some pretty complex phenomena in some pretty simplified ways. So in instances where I'm talking about neurobiology or physiology, I just want to note that I'm talking about the current theories based on our best understanding and current technology, but recognize that these things might evolve as our understanding develops. So going into this, let's talk a little bit about what MDMA actually is. So 3,4-methylene-deoxymethamphetamine is a ring-substituted amphetamine analog of the phenethylamine class. Although it has chemical similarities to methamphetamine, it actually has very different physiological and qualitative properties. They actually had to create a new class of substances to encompass MDMA, so they created the class of entactogens or empathogens, which means to induce feeling or induce empathy. So MDMA is most commonly known for its connection to the street drug ecstasy, but what we're talking about here in terms of using it as a clinical treatment, we're talking about using MDMA in a medical grade and pure form in very controlled dosages. So where ecstasy on the street is often adulterated with other substances and can range wildly in dose range, we have very tight control over the doses and the purity of the MDMA that we're using for this treatment.
Will?
Yep.
There's actually a question in the chat that touched on that. Could you just clarify how the dosing scheme works, like how much and what the interval is? Or,
yeah, so I'll get into what the MDMA therapy program looks like how often it's done, but generally, just to jump a little bit ahead, when I'm talking about MDMA-assisted psychotherapy, people are generally doing 3 MDMA therapy sessions spaced 1 month apart. So this whole therapy process is usually about 4 months, and they're only taking MDMA 3 times. And so the doses that are used they've tried different dose responses in different studies. And so some of them have looked at 75 milligrams of MDMA, but the most common normal dose is 125 milligrams of MDMA as a starting dose with a 75 milligram booster dose, usually at 3 to 4 hours.
Thank you.
Yeah, no problem. And so MDMA had originally been developed in 1912, but it was not until the 1970s that it was actually first explored in human subjects. So in the 1970s, it was rediscovered by the chemist and pharmacologist Alexander Sasha Shulgin, and he found that this compound displayed unique and profound effects on how people would experience themselves in the world, and created an openness and connection with self and others that really lended itself to psychotherapy. So over the 1970s and early 1980s, while MDMA was still legal, it was being used widely by psychiatrists and psychotherapists to aid in therapy process for all different kinds of things. Patients were recounting that it was like doing a year's worth of therapy in a single session. It was eventually made illegal in 1985, which is kind of a whole other story to itself. And it would take about another 20 years before FDA clinical trials would start looking at MDMA as a clinical treatment, which is taking place now and is almost through the final phase. So this chart was put together based on some of the common understandings of MDMA's neurological and physiological effects. And this was actually the focus of one of my studies where we interviewed participants about their experience with MDMA during these clinical trials. So this table lists the known physiological and neurochemical actions of MDMA, and also shows what we have theorized to be the observable effects that these create in the context of therapy. So here we can see that some of the primary actions of MDMA include release of serotonin at the 5-HT1A, 1B, and 2A receptor sites. And so with this, we see increase in self-confidence and elevation of mood, decrease of anxiety, aggression, and defensiveness. And at the 5-HT2A receptor site, which is commonly thought of as the psychedelic serotonin receptor site, we see slight alterations in perception of meaning and ability to develop new insights. So really allowing someone to see things from different perspectives and think outside the box from the way that they normally do. We also see activity at the alpha-2 adrenoceptors, which increase relaxation and calmness and reduce hypervigilance, which is especially important as we're talking about using this for PTSD. We also have release of oxytocin, which improves feelings of attachment, trust, and empathy, and reduces feelings of social rejection. Again, this is very important to a therapy process, which in many cases, especially for PTSD, can take many months, if not years, to develop a trusting relationship with a therapist to actually do trauma work. So then these last two become even more especially important as we're talking about working with trauma. So with MDMA, we see reduced activity in the amygdala system. And so the amygdala is the part of our brain that we generally speak to as the fear and anxiety response center. So it's the part of our brain that is associated with assessing if we're in danger or not and triggering us to respond by going into fight or flight mode. And this is something that becomes very hyperactive in the course of PTSD, where people feel like they're constantly in danger, even when they may not actually be. So with MDMA, we actually see reduced functioning in the amygdala system, which allows somebody to talk about traumatic memories or talk about stressful events without having the same physiological response that they would normally have that would get in the way of being able to talk about those things. And then finally, here we have increased prefrontal cortex activity. And with this, we have increase of reasoning and logical thinking, increased levels of shared empathy and pro-social functioning, And really, the prefrontal cortex is where our best decision-making, rational thinking, and our reasonable personality reside. So when we analyzed participant interviews from after their treatment, one of the areas we looked at was how they experienced MDMA in relation to the therapy process and how they thought it might have altered the experience with the therapy. So participants talked about a number of ways that they experienced MDMA affecting the therapy process and how the therapy as a whole was different from what they had tried in previous therapies. So what people talked about was increase in self-confidence, self-awareness, openness, and positive emotion during these sessions, a decrease in fear, anxiety, and self-judgment, decrease in hypervigilance, physiological activation, and fight or flight response to traumatic and stressful memories. And they also talked about how they were able to quickly develop a strong bond of trust with the therapist that was important for doing this work, as well as allowing them to process traumatic memories with greater compassion and self-awareness. So in order for us to talk about why MDMA could be a suitable treatment for PTSD, let's just spend a little bit of time talking about what PTSD actually is. So post-traumatic stress disorder is a series of mental health symptoms that develop following a traumatic incident or a series of traumas. So symptoms look different for different people, but they generally involve three main categories of symptoms. So these include re-experiencing the trauma, which can often look like having nightmares, having flashbacks, or intense memories of the trauma reoccurring, hyperarousal, which is kind of like we talked about, that increased amygdala functioning where somebody is constantly on the edge of fight or flight response, feeling like they need to protect themselves in situations where that may not actually be needed. And then avoidance symptoms, where someone is just trying to avoid anything that might trigger the trauma. So these might be places, specific people, sounds, smells, but it also might be as hard as trying to avoid memories, thoughts, or feelings, which can be very, very difficult to get away from. So this is commonly why people with severe PTSD might try to avoid those feelings and thoughts using substance abuse or dissociating or through a number of other means. So in PTSD, we see a number of changes in the brain. Notably, like we talked about, we have an increased functioning or hyperactivity in the amygdala system, which is triggering a person to feel like they're constantly in threat when they may not actually be. We have decreased functioning in the prefrontal cortex, which controls our personality, reasoning, rationality, and decision-making. And so with the prefrontal cortex functioning decreased, it actually makes it difficult for the prefrontal cortex to override the amygdala to tell it that this person is not actually in danger and they don't need to go into fight or flight. So you have the system where someone is constantly being triggered and they don't have that response of the prefrontal cortex to bring them back to rational assessment of a situation. Additionally, with the prefrontal cortex being less active, people with PTSD may experience difficulties remaining rational during stressful situations, managing emotions, and sometimes report not feeling like themselves. There's also research suggesting that the hippocampus is affected by PTSD, suggesting that memories, traumatic memories, may be stored and queued differently than other memories. So of course, this can look different for different people, but when somebody is constantly reacting to the world as if they're in danger and avoiding anything that can possibly trigger a traumatic response, these symptoms really get in the way of people's lives and their ability to live normal lives. So we often see really strong impacts to someone's quality of life, high rates of substance abuse, self-harm behaviors, and suicide as attempts to avoid the intense feelings associated with PTSD and many other issues that come out of this as well. And so while it has been thought that about 50% of people in the world will experience some major trauma in their lifetime, it seems closer to about 1 in 12 people who will actually experience symptoms of PTSD and end up qualifying for a diagnosis at some point in their life. So PTSD has proven to be incredibly difficult to treat, and the symptoms actually can stand in the way of progress in treating it. So in this image, we see 4 common treatment types for PTSD. So on the left side, we have medications. Below that, we have traditional talk therapies. To the top right, we have novel treatments like meditation and yoga. And then below that, virtual reality exposure therapy, which is kind of a newer model for working with certain types of PTSD. So I'm going to focus primarily on the 2 traditional types of treatment for PTSD, which are by far the most available to people seeking treatment for PTSD. So medications are often the first line response to PTSD symptoms. The goal of medications is to target specific symptoms with the hope of relieving them. What this can look like for PTSD, however, where there's many different types of symptoms that can come out of having PTSD. So someone might be having difficulty sleeping, high anxiety, difficulties with depression and motivation, social issues. Someone might end up on 5, 10, or 15 different medications trying to manage these symptoms. And that was actually very common for people coming into our studies, was that it was not uncommon for someone to be on 15 medications when they came in. So the difficulty with medications is while they can relieve certain symptoms, they only target symptoms by covering them up. They're not actually designed to get at the underlying reasons why those symptoms exist in the first place. Additionally, there's issues with medications like they must be taken every day to have the ongoing benefit. They come with side effects, and then just the other issues inherent with needing to be dependent on a medication to feel okay. So psychotherapy, on the other hand, goes about this in a different way. So of course, there are many different types of psychotherapy that deal with trauma in different ways. So you might have some like cognitive behavioral therapy, where the focus is working on building coping strategies or changing someone's thought process to try and better cope with the symptoms of PTSD. But many of the psychotherapy treatments for PTSD are what we call trauma-focused therapies, where the goal is actually to eventually process the trauma, going in to pull out that traumatic material in hopes of actually getting to the root cause of what is causing those issues. So these trauma-focused therapies have shown to be the most successful therapy type for actually creating long-term change. However, the difficulty with these traditional treatments is they can be incredibly hard for people to tolerate. So because people with PTSD tend to have a really hard time building trust and feeling safe with a therapist, and also easily get triggered by anything that brings up the trauma, going through these therapy processes can be incredibly difficult as people start to open those doors to the underlying traumas. And so what can happen is things can actually get worse before they get better, as someone starts to undo some of those wounds that have been closed up for a long time. Things can start to get a bit harder, and more issues can come out as they start that process. So generally with traditional psychotherapies, it should be a long process of building up trust, building up safety, and really preparing to go into the traumatic material when a person is ready. But this can take many years of therapy to even get to that point, and it's still a very difficult process. And many people actually experience these treatments as quite averse. So there are also high levels of people dropping out of PTSD treatments, higher rates of substance abuse, self-harm behaviors, and even suicide attempts that can come out of trauma treatments if they're not held very carefully. So MDMA-assisted psychotherapy aims to take the most effective parts of pharmacotherapy and psychotherapy to create a situation where someone has their symptoms managed enough during a therapy session to be able to process traumatic content without having the physiological response that has blocked them from being able to work on it previously. So this does aim to target the underlying causes of the symptoms, but rather than just covering them up, the goal is also to make it more tolerable of a process to actually do that than traditional psychotherapy. So just to recap, we can see side by side here the effects of PTSD on the left and the effects of MDMA on the right, and we can see how they're basically opposites of one another in what they do physiologically. This means that when we administer MDMA to a participant with PTSD, they are able to participate in a therapy process without the overwhelming effects of PTSD getting in the way of the therapy. So when they take MDMA during the therapy, they're able to calmly and thoughtfully access their traumatic memories and process them within a zone of support and trusting safety with the therapy team. And what we see is this appears to lead to dramatic drops in PTSD symptoms during and following the treatment. So we started touching on this a little bit earlier, but just to clarify a little bit more what we're talking about when we say MDMA-assisted psychotherapy. And I know I keep saying it in long term because it's important to clarify that we're not just talking about taking MDMA on its own. So this whole process of MDMA-assisted psychotherapy is a multi-stage process that involves an intensive therapy process in addition to just taking MDMA. And we'll talk a little bit about why that's important. So MDMA-assisted psychotherapy was developed by the Multidisciplinary Association for Psychedelic Studies, or MAPS. And MAPS is a nonprofit research organization that has really led the drive of psychedelic science and has put their focus on taking MDMA from an illegal substance to an FDA and DEA approved clinical treatment for PTSD. So they've really gone from the groundwork of designing this therapy, putting it through clinical trials, and lobbying to get it all the way through approval. So what this treatment looks like is 3 MDMA-assisted psychotherapy sessions, generally spaced 1 month apart from each other. So these sessions are generally 8-hour intensive therapy sessions with a trauma focus. So these 8-hour therapy sessions are always done with a 2-therapist team. So that's a very important part of this process, is just the extra support of having 2 therapists in process through this entire treatment. So these MDMA therapy sessions are combined with weekly non-drug therapy sessions for preparation and integration. So this means on a weekly basis, people are getting 1.5-hour therapy sessions with the same 2-therapist team to prepare for those MDMA sessions and also integrate what is coming up in them. So this treatment is currently in phase 3 clinical trials, which is the last round of clinical trials before it can be approved as an accessible treatment. And actually in 2018, MDMA-assisted psychotherapy was called the FDA's Breakthrough Therapy of the Year. So the FDA felt that this treatment was meeting a certain criteria of safety, and it was so successful that they wanted to actually fast track it through the clinical trial process. So right now it's actually scheduled for 2022 to be a fully approved and accessible treatment. So to wrap up this section, I just wanted to share one more quote from another participant from one of our qualitative studies. I think they explained the experience of MDMA treatment really beautiful. So they said, "I think that the MDMA gave me the ability as though I was capable and safe of tackling the issues. Whereas before I feared those traumatic thoughts and I tried to avoid them at all times and avoid the things that reminded me of those thoughts. I think it allowed me to feel safe in my space, of being able to fight it. I felt like I had the ability and the tools, whereas before I was unarmed, unarmored, and had no support. And this type of environment, with the therapist, the catalyst drug, and everything else, it felt as though I had backup. Now it was safe, and I had my tools and my weapons to be able to tackle the obstacles that I never had before." So I think this speaks really beautifully to the importance of that whole system, that it's not just about taking MDMA and feeling better, but it's that the MDMA, in addition to this relationship with the therapist and the whole therapy process, that really creates this change and creates this, this movement of trauma. So these quotes, as well as some of the lessons that we have learned about this treatment, have come from our qualitative research studies. So just briefly, I want to touch on what I mean by qualitative research and what that looks like in this context. So in short, there are two major data collection methods in psychological research: quantitative research and qualitative research. The quantitative research is focused on seeking objective findings through numbers by removing subjective experience from the equation as much as possible. This is what is commonly used for clinical trials, as it's very good at evaluating how much change occurs across big groups of people. Quantitative research is an incredibly important factor of clinical research, as it can look across many data points to see if a treatment is safe and effective in a large population. Qualitative research, on the other hand, is more focused on seeking subjective experience. So this is normally done with smaller groups of participants, but goes into much greater detail than quantitative studies are able to do. The goal of qualitative research is to understand the experience of participants within a phenomena, with the hopes of understanding the intricacies of how that experience works. So just about this slide, while I do not have physiological and brain imaging studies on this slide, I do think that they're also such an important method of data collection. And I think it's really important that we're able to utilize all three: quantitative, qualitative, and physiological studies to really have the best chance at understanding something from different angles. So when I had started this work, there had been very few qualitative studies in the psychedelic sciences, and there hadn't been any done with MDMA, with this MDMA treatment. In recent years, we have shown that qualitative studies are an important piece of understanding what's happening in these treatments. So in the psychedelic sciences, qualitative research has helped us to develop a deeper understanding of the phenomena in the quantitative results, helped us to explore phenomena that might be missed by quantitative results, things that aren't picked up when you're just looking at the numbers, to understand participant experience with the treatment, and also to give participants a voice, helping participants to express their participation in this treatment and how important they are to this process. Also, qualitative research has an interest in putting language to ineffable experiences. So this is one that I think is really interesting. So part of psychedelic experience is that we have what we call ineffable experiences, or things that we just can't explain. So part of having a psychedelic experience might include a number of different journeys or sensations or experiences that we just don't have language for. We just don't have words for how to describe those things. And so part of this process of qualitative research is really seeing how people do try to describe those ineffable experiences to get a better sense of how can we describe them, how can we understand these experiences that are just completely outside of our traditional realm of understanding. So qualitative research also focuses on how does this treatment work and how is it experienced, versus the quantitative research that is really only interested in does it work and is it safe. So it provides that other level of looking at how this therapy might work, how do participants experience it, and how can we actually learn from that to potentially make it better. And again, qualitative research focused on individual experience rather than large group norms, but these individual experiences can go a long way to helping us understand what's happening in those large groups as well. There are many methods of doing qualitative research, but the majority of qualitative studies in the psychedelic sciences use interpretative phenomenological analysis, or IPA. IPA has been called the qualitative methodology of choice in healthcare research, and is set up really well to evaluate a person's experience from before, during, and after going through a study or a treatment like this. So IPA particularly explores meaning and sense-making. So the aim of IPA is to explore in detail how participants are making sense of their personal and social world. And the main currency for an IPA study is the meaning particular experiences, events, or states hold for a participant. So what this translates to is that our studies are very interested in how participants make sense of their experience with MDMA. Particularly, we're interested in exploring how did they experience this treatment? Why do they think it was or was not successful for them? What do they even mean by being successful? And how do they make meaning from their experience before, during, and after this treatment? So here we can take a look at how a qualitative study generally runs. So although a qualitative interview can really be placed at any point during a study, we have found that if you only have an opportunity to do one qualitative interview, which is very common, that it makes the most sense to do the qualitative interview as a follow-up to the treatment. So rather than doing the qualitative interview where we're going in and interviewing participants at length about their experience, rather than doing that in the middle of their treatment, it makes sense to do it after they've gone through their entire treatment and have actually had some time to reflect on what that treatment means and how the outcomes are starting to shape out. And so often our studies have done either 3-month follow-up interviews or even 1-year follow-up interviews, which have different pros and cons. And so the reason that it's very common to only have the opportunity to do one single interview is that it's just a very time-intensive process of not just getting these interviews, but also for every hour of interview that you have, it is an incredibly long process on the back end of what we actually do with that in the qualitative study. So in our studies, this is how things generally look. Based on this slide, participants complete the MDMA-assisted psychotherapy. They go through all of their MDMA sessions, all of their follow-up sessions, and there's a certain point that they call the endpoint of the study. After that, we have our whatever time frame we're using, say it's a 3-month time frame, where we have our participant qualitative interviews. So these are usually 1.5 to 2 hour in-depth interviews with the participant, exploring a range of different issues about their experience, what their life was like before the study, during the study, and after the study. And we look at so many different angles to try and understand what it's like for somebody to go through this treatment. After we have these interviews complete, they're transcribed, so they're all in text form. And we have our qualitative team, which is often a 4-person research team. I found that to be a really good number. The qualitative team develops what's called a code book. And so we do that by going through the first interview and sometimes up to the first 3 interviews that we have, going through in deep detail, line by line, trying to find important themes, important things that we want to capture, different areas that we want to focus on, and create those into codes. So for example, we might have a code of PTSD symptoms. And so we can have a code for any time a participant talks about PTSD symptoms, we can mark that section with the code PTSD symptoms. So on the end, when we have all of these done, we can see all of the times that all of the participants have talked about their PTSD symptoms, so we can put them side by side to see how they differ from person to person, how they're similar, and get a sense of also how those symptoms change over the course of this treatment, from before, during, and after. So generally we'll have dozens of different codes that look at all different things, all different angles. And once we have that code book developed, then we move into the actual coding process, where the team then takes that code book and applies it to the remaining transcripts of the other interviews. So going through, again, coding line by line to try and capture and categorize the things that are coming up in those transcripts. Then the team moves to the analysis phase, which is taking all of those codes that we've developed, putting them in a analysis program, and really taking, often it can take months to do this, to go through every single angle to try and see how these codes come in contact with each other. What does it mean for similarities between participants, differences between them? How can it help us understand their experience and the different parts of this treatment? So it's a very, very time-intensive and in-depth process to do. But a lot of really amazing stuff can come out of that. And then finally, after the analysis phase, we move on to publication and presentation of the data. And so these qualitative studies can be very time-intensive. So the study that was sent out as reading material for this class was one of the first qualitative studies that I finished. That took about 5 years to complete, from creating the idea to the actual publishing of that study. At this point, I've designed a model that's much more streamlined and learns from a lot of the things that we picked up in that study. So now a lot of the students that I'm mentoring to do these qualitative studies can often do them in a year to maybe 2 years, depending on how many participants, how many interviews, how long they are. So it's become more of a streamlined process. And we've tried to create more uniformity between these qualitative studies so that people don't just have to reinvent the wheel every time we're doing a new study. So let's move into what happens after someone goes through this process of MDMA-assisted psychotherapy and is able to face their trauma with the benefits of MDMA and the support from the therapists to be able to do that intensive trauma work during the sessions. So this slide is from MAPS, the Multidisciplinary Association for Psychedelic Studies, and is an accumulation of all of the phase 2 clinical trials. So I think this encompasses over 100 different participants that were in a number, maybe 4 or 5 different phase 2 trials. And so there's a number of important things that come up in these images here. So the circular image on the left side, if we look at the darkest line on the outside, this indicates the percentage of participants who qualified for a PTSD diagnosis going into the treatment. So this makes sense that 100% of participants going into the treatment met criteria for PTSD. And actually everybody qualified for really the highest severity of PTSD, and they all had to be treatment resistant, meaning they've all gone through other therapies and tried multiple medications without much benefit. So looking at this blue line inside, this is looking at the participants in this process who only got psychotherapy. So they did not get the MDMA, but they went through the entire process just getting a placebo instead of MDMA. So this is the placebo group of the study. And what we see is about 20% of those participants no longer meet criteria for PTSD after this 4-month process, which in itself is a pretty amazing finding, because there's not too many 4-month-long PTSD treatments that can get 1 out of 5 people to not be diagnosable with PTSD after just 4 months. So that alone is still pretty cool and speaks to the intense nature of just the therapy process. But what's most important is this orange line, where we see that for the MDMA group, so the group that did get those 3 MDMA therapy sessions, that after this study, 77% no longer met criteria for PTSD. So 3/4 of people who did this study do not have PTSD anymore at the end of this 4-month treatment process, which is an unheard of number in any kind of clinical treatment. So that's a pretty amazing factor. Something else that's kind of goes beyond that is on the right here with this bar graph. This is looking at the severity of PTSD symptom scores based on their CAPS score. And these are the combined scores for the entire group. So we can see this dark line is the before treatment severity of symptoms for these participants. And we see that their CAPS score on average was about an 80, which indicates a very high severity of PTSD symptoms. 2 months after the MDMA treatment, the average PTSD symptom score is close to a 30 or a 35. And the cutoff for a PTSD diagnosis on the CAPS is a 40. So we see that 2 months after, the average score on the CAPS has gone below diagnostic criteria. But the most important part of this bar graph here is this orange line, which shows that 3.8 years after they went through the treatment, that their symptom severity is actually lower than it was 2 months after the treatment. So this is a really important note, that when you are actually able to do a treatment that gets to the core of the trauma and doesn't just cover things up, it actually allows for somebody to continue improving, to continue getting better in the long term, not just expecting benefits for a few months after a treatment. And so these are people that that did not receive MDMA after that initial phase of 3 treatments. So these are pretty amazing findings. So our qualitative studies found a number of important additions to these findings. So we found that regardless of the degree of symptom change, so whether somebody had all of their symptoms decrease or only a small percentage of their symptoms decrease, we saw that all of these participants talked about improvements to their quality of life. These included improved self-awareness, improved relationships and social skills, reduced medication use and problem substance use, engagement in new activities, and openness to future therapies. And so remember the participant Jim that we started this presentation with. Jim was one of these people. If we go to this last slide, he was one of these 23% that still met criteria for PTSD. So looking at this, you would think, okay, these 23% of people failed the treatment. They didn't get better. They still have PTSD. But what we were able to find in our qualitative studies was that even for those people, they talked about this range of improvements that they experienced regardless of if their symptoms changed or not. Participants also reflected the importance of the multifaceted treatment, talking about the importance of the combination of MDMA, the relationship with the therapy team, and the ongoing preparation and integration sessions. So again, noting that this is not just something where you take MDMA and feel better. It's really a process of the MDMA allows a therapy process to happen, and that intensive therapy process is actually what creates the change. And all of these elements are important for that process to happen safely and effectively. We also looked at people who had some return of PTSD symptoms in the year following treatment, which there was actually not many. I think from the study that I had published, we had 19 participants. 6 of them had some minor return of PTSD symptoms in the year following treatment, and we found that 5 of those had a major stressful event or another trauma in the year following treatment. So we found that that was a common cause of why somebody might have some regression of symptoms following MDMA therapy. So just to kind of wrap up, I wanted to share one more quote. And while we have hundreds of incredible quotes that come out of these studies, I just wanted to end on one that I think sums up the experience of how MDMA-assisted psychotherapy can alter someone's ability to manage symptoms and gain from the therapeutic process. So this person talked about that I had a lot of defenses going up into the therapies that I had previous to the MDMA, and it made accomplishing any substantial breakthroughs in what I was going through pretty impossible. So with the MDMA, it broke this hard outer shell that was up that kept me from being able to connect with the therapies I was going through. So now when I go through and I'm doing my current therapy, I understand the material and how it's beneficial. So I thought this was really important to just speak to how many of these participants are finding that just from these few MDMA sessions, there's actually a notable change in how they live moving forward and how they're able to connect with the ongoing therapies or things that help them become healthier and better people moving forward. And I think that's the end.
Wow. Thank you so much. This was cool. Yeah, that was super cool. So I want to open up the floor to any questions or comments. I've got a bunch, but
Same.
yeah, but if anybody has any questions, feel free to just chime in, post it in the chat, do the raise hand thing. Annabelle, go ahead.
Hi. So this whole thing is just super, super, super interesting to me. And one question that I have is when you specifically talked about the people who had a regression of symptoms, and if this was like a normal, like FDA approved treatment that people could just get, would going through the MDMA assisted psychotherapy help them assuage those new symptoms, or would it not be recommended?
I'm sorry, do you mean having them go through another MDMA session later? Is that what you're asking?
Yeah, so it's like if they had already done it previously and it hadn't worked out or symptoms had regressed, would it be like wise to advise them to go through it again or to find another sort of therapy?
Right. So because of the limited nature of clinical trials, the treatment has very much been set at these 3 MDMA therapy sessions. But one of the things that that has been looked at is really what would the optimal number be, and is it possible to have the treatment where there's an initial set of these 3 therapy sessions, 3 MDMA sessions, that might be followed up by a booster session at different intervals. And so that was something I actually assessed with the participants in our study, and many of them said that they would either have really loved a 4th MDMA session in succession, or that maybe it would be helpful to do maybe once a year as kind of an MDMA tune-up session. So I think in the future, when this is an approved treatment, there will be more option for really assessing the needs of each individual client and seeing if that initial phase of 3 treatments needs to be followed up by maybe booster sessions, or it may look different ways when it's actually employed.
Thank you. It makes a lot of sense. Therapy is different for everyone, and it seems it's definitely going to change once the FDA approves.
Right, exactly. And we definitely would be encouraging participants to get other therapies as well. And it seems like after people go through MDMA therapy, they are more open to traditional therapy and working on different things to benefit health. So that's an important thing to be following up with also.
Thank you.
We have a couple questions in the chat. This one's from Anna, and it is, how would this be implemented on a larger level? How would normal therapists have to be trained in MDMA-assisted therapy, or would there be therapists that are specifically trained and only work in this?
Yeah, thank you. It's a great question. And so that's a big part of this process now, is figuring out how this is going to look on a large scale. And so I know that's one of the things that that MAPS has been thinking about from the start of this process, is what happens when this is a legal and accessible therapy. And so MAPS is in the process of actually training therapists to be able to be, I guess, not licensed, but approved to provide this treatment once it becomes legal. And it will be a situation where, at least at this point, the way it's set up is MAPS is going to have, I believe, really the only option for being trained in MDMA-assisted psychotherapy through their model. So it's going to be a process of needing to be a licensed clinician, but they are also thinking about opening it up to some other groups of people who may not be licensed clinicians. Because it's a 2-therapist team, you might have a situation where you have one psychiatrist and a nurse, or a psychotherapist and a religious professional. As long as one person in the room is a licensed clinician, there might be ways to make that work. But everyone who's going to do this is going to have to go through an intensive training process. to be approved as an MDMA therapist.
Awesome. So we have another question in the chat from Landon. He says that MDMA has been known to have a strong emotional come down or hangover in the days following a dosage. Was this an issue accounted for during these studies?
Yeah, definitely. So what, that was one of the things that we really looked for, was some of the downsides that MDMA has associated with it, the difficult come downs, Blue Monday, Suicide Tuesday is kind of the rave language of following up after a long MDMA session. But really what we see is that those things are associated with many different factors of taking MDMA recreationally. So in recreational settings, you have people taking much larger doses of MDMA that is normally adulterated with other substances or may not have MDMA in it at all, but is sold as MDMA. You have people staying up all night, exerting a ton of energy, not eating normally, not sleeping normally. All of these things are really thrown off, which further that mood shift the following day and in the next couple days. So what we see in the clinical trials is that we have people take the very moderated dose of pure MDMA very early in the morning. So they're actually able to not throw off their sleep schedule at all. They're able to eat normally. They're not exerting too much energy. And we've actually found that doing it this way really limits almost any after effect. So when people wake up the next morning, the majority of participants are not having a difficult time after. We found that some people did have some alteration of mood in the day after, or just feeling lethargic or feeling a little bit off, but that did tend to resolve much more quickly than we would expect in recreational settings.
As a follow-up to that, does that also mean that you don't follow any of the classic supplement schedules like enrollsafe.org and stuff like that?
So in the clinical trials, those could not be followed because it was in the clinical trials, you need things to be very clean, and you don't want to introduce any confounding variables to the mix. But when it is a legal accessible therapy, there is room to even further add supplement schedules into the mix to just further add protection and benefit. And also just to note here that when we're seeing MDMA be used in this way, in the dosages we're talking about in medical grade pure form and at once a month for 3 months, we're seeing that there's really no negative neurological effects, no adverse events came up in the course of any of these clinical trials with hundreds of participants taking MDMA. So it's really, really controlling for any negative issues that could come up from it.
Wow, yeah, that's fascinating. I think there was another question in the chat. Does MDMA carry a risk of having a bad trip like other psychedelic drugs? And how does that affect the therapy?
Yeah, that's a good question. So, psychedelic drugs, we talk about, bad trips or difficult experiences is part of the language of psychedelics. I definitely fall on the side of trying to make a distinction between difficult experiences and bad trips. I think that it's important to note that even difficult psychedelic experiences can be important growth experiences if they're held in a safe and contained way. So even if something is especially challenging, it can be hugely important, especially in therapy. And I actually helped to supervise a program called the Zendo Project, which exists at Burning Man and other festivals, where our whole mission is to work with people who are having difficult psychedelic experiences and support them in turning those into positive growth experiences by creating a completely safe and comfortable zone and support zone for them. So MDMA is far less likely to create difficult experiences than classic psychedelics, just by the way that it is. All those things that we talked about on the neurological and physiological slide, it is really designed to create positive feelings. It's pretty hard to have a bad time on MDMA, but in the context of this therapy for PTSD, it's also not an easy experience. So many people in this in our studies talked about that, you know, this is not a fun thing to do. I mean, you're doing this intensive trauma therapy where you're talking about some of the most horrendous things that have ever happened in your life. It's a little bit easier because of the MDMA, but it's still not something fun that you would ever want to do if you weren't doing that therapy process. So I guess to say it's not common to have bad trips or difficult experiences on MDMA. It's possible to have MDMA create some level of anxiety, especially during the come up phase, because MDMA does have some stimulant effects. So sometimes people can feel their heart rate increasing, which is very common, and start to develop anxiety. So we do a lot of preparation for what to expect when taking the medicine. So someone knows, okay, my heart's racing, that's totally normal, it's part of the process. I have these tools to kind of breathe back through it and slow things down. And I have these therapists here who I trust and I know will get me through this. So all those things help the process of reducing the likelihood of having a difficult or challenging experience.
Cool, thank you.
I have a question about how do you address the sort of like stigma and reputation that psychedelics have, especially amongst other scientists? Like, I'm asking because I'm in one of my cog sci classes. Like, we learned a little bit about psychedelic therapy, and the professor's talking about how great the research is, but still sort of talks about it along the lines of like, oh, peace and love, like sort of kind of flippant, a little dismissive language. So I'm just wondering, how do you go about addressing that?
Yeah, that's an interesting situation. I'm just thinking about, like, I think it's awesome that it's even being discussed in that course, even if it's with a little bit of flavor to it. When I started this work, it was an uphill battle to even have somebody talk about psychedelics in the context, especially in the context of therapy. When I started proposing my dissertation to do an MDMA study, 9 years ago, I got a lot of pushback that, this isn't something that is happening. There's a lot of misunderstanding about, what it was. And it was really important to keep coming back to the research and coming back to the lit review that this is how well this research is being done, that it's being done by phenomenal researchers, phenomenal scientists that are going above and beyond to do good research because they know it's going to be pulled apart at every level. So I can just say, I think one of the best things to do is to go to a psychedelic science conference. If you have the chance to do that, and I hope we get the chance to do that in person again, because they're really special events where you have, this interesting mix of people who are definitely, have taken psychedelics for many, many years and have a lot of different ways of expressing that. But it's really people showing up as doctors, as researchers, and showing that these things are effective and useful through the Western medical model of doing research. So I guess to speak to your question, I don't know, in a class setting like that, it might be difficult, but what I would suggest is just continuing to write papers on the subject, continuing to show your perspective in a way that you're able to back up that perspective with data, and just continuing to hold your perspective.
Cool, thank you. Okay, there's been a few questions. Not sure where we left off here. Yeah, so I guess this kind of addresses, or it sort of ties into that question earlier, and it's from Sarah, just about, are psychedelics still stigmatized within the scientific community? Is that widespread or just among older folks?
I would say far less than even 5 years ago. So at least now it's a concept that most people have heard about. I mean, it's been on the cover of Time magazine. It's been in every publication, every normal publication that's out there is talked about in some way, psilocybin or MDMA or psychedelics. So in the last 5 years, it's become way more out there in the world where people generally know that it's a thing that's happening. I've experienced mixed results in the clinical world. So I've had some experiences, like I gave a talk about MDMA therapy to the San Diego Psychiatric Association, speaking all to psychiatrists. And I thought that there would be a really mixed reception and people that were not quite ready to hear, especially as psychedelic therapy kind of goes against the long-term model of how we do psychiatry. But I found that pretty much everyone in that room was really excited to have a new tool and to have something that worked better. I found that there are definitely old guard psychiatrists and clinicians who really want to hold on to what they have, and they are afraid of new things coming in. But I think now there's also a lot of psychiatrists and clinicians who similarly are feeling like what we have isn't working good enough. These tools that we have, these medications, are not doing the job to really help people enough. So I've gotten a lot of openness of people who are interested in exploring this and understanding, how do we do this safely? What does it mean when we're talking about these treatments, that we're not just giving people MDMA to take home and do on their own and expect that they get better, but that there is a system of safety and support and clinical elements built in. So that's yeah, I think that's a very important part of it. But yeah, there is still definitely pushback. There's still those people that hear, like, wait, you're giving what to who? You're giving ecstasy to war veterans, and but I usually think within 5 minutes I can have somebody understanding what I'm talking about, why it's important, and have them at least open to being on board.
I would have a hard time believing that after giving all the information you gave us today, people would still be like, no, that's a bad idea.
Yeah. I mean, I think people have reasonable concerns. I think it's totally reasonable to be concerned about new treatments and wanting to make sure they're safe and effective. But some of the biggest things that we were, concerned about or saw concerns with these treatments have just become non-issues. Like, one of the big things was people were thinking, once you give someone MDMA for treatment, they're going to want to go take MDMA every day because it felt so good. But what we found in our follow-up was that it was actually a deterrent for people taking MDMA in the future, because it was so connected to this intense therapy process that people said, like, I can't imagine taking MDMA and going dancing. Like, it doesn't compute why someone would do that, because for them, MDMA is tied to trauma work. So it actually seems less likely that these people will take MDMA outside of a therapeutic context.
Cool. I think we had a couple more from the chat. What are the dangers of MDMA outside of a therapeutic setting?
Yeah, the biggest dangers of MDMA would be that a lot of it is not MDMA. So a lot of what's sold as MDMA can be any number of other substances that have been sold as MDMA for years. There's a class called cathinones that have similar effects to MDMA, but it's actually much more neurotoxic and can actually overdose much easier. So the first thing that you want to be doing, taking any substance outside of a therapeutic context, is to be testing any substances you have. So you should be having multiple reagent testing kits, which are legally available online, just to make sure that what you think you're taking, you are actually taking. It's kind of the first step in the harm reduction toolkit. But say you are getting pure MDMA, you're able to measure the dose properly. The concerns with taking it, again, things get compounded when taking it in settings where people are dancing all night, not drinking enough water, drinking too much water, not sleeping, not eating. All of these things can further compound any issues that could come up, like having difficulties in the days following MDMA. There's some risk for what's called serotonin syndrome, but it's actually a very uncommon thing to come up with MDMA, but that's where somebody has too much serotonin released in their system, which can create a number of issues and potentially lead to seizures and actually passing away. But that, again, is something that very rarely comes up with actual pure MDMA. I guess the other thing to note is that there's been a trend in the last 2 years or so that has not been as big of a deal in the US, but in the UK and Europe, and surely will be moving over to the US, is there's become a new way of creating MDMA, which actually is much more affordable and more accessible for people producing it. And so there's been this turn where people producing MDMA or ecstasy pills are putting huge doses of MDMA in their pills. So it's not uncommon to see 300 milligrams or 500 milligrams in an ecstasy pill in the UK or in Europe right now. So that's just one thing you want to be really mindful of, is starting low on your dose and making sure you tolerate it well before taking any more.
Yeah. So we have a couple raised hands. Sarah, do you want to go first?
I was wondering where MDMA ranks, like, in its effectiveness among all of the psychoplastogens, like in the therapeutic setting.
Where does it rank among them for treating anything in particular?
PTSD.
Yeah, so thank you. So PTSD, so MDMA, and kind of what this talk is meant for, and I've tailored it to even be more suited to that conversation. But MDMA is really uniquely suited to treat PTSD, more so than any other psychedelic or any other medication that we've come across. Just, I mean, the slide that was in this talk, where we see the effects of PTSD and the effects of MDMA side by side, and you see that they're kind of exact opposites in the way that they affect the body and the brain. MDMA just seems to be uniquely qualified as a treatment for PTSD. It's not the only thing that could benefit PTSD, but I think there's other risks associated with other compounds and other psychedelics. So, for example, we do currently treat some forms of PTSD with ketamine, but ketamine-assisted psychotherapy. So again, I would never recommend, or I would not recommend someone with PTSD to go to a ketamine infusion clinic where they're not doing any therapy, but they're just, someone goes in, they get an infusion of ketamine, and the pharmacological antidepressant effect is supposed to be helpful. Because going into that altered state with trauma can open a lot of things up more quickly than someone is prepared for. And so when someone has traumatic history going into ketamine-assisted psychotherapy, we often take extra time in preparation, helping somebody understand what this treatment is going to be like, how do we hold their sense of consent and sense of control through the whole process, develop safety in the relationship, and then move very slowly into the ketamine part of the treatment. And we found that it has been quite effective in certain cases, but if MDMA was legal and accessible, I think that would be the first choice.
Thank you so much.
Hi. Well, you kind of answered my question that I had with what you just said, but I was wondering if you could maybe speak a little bit more about ketamine. And my understanding of it is kind of as a dissociative. And I'm wondering if you would agree with that, and also if MDMA has similar effects, and why specifically you would put MDMA much above ketamine for dealing with something like PTSD.
Yeah, so ketamine is a dissociative anesthetic. That's the class of substance that it's in. But it also has powerfully psychedelic effects in certain dose ranges. And also when we say dissociative in terms of ketamine or in terms of certain substances, that's often a different type of dissociation than what we talk about with PTSD. So those are often two different types of dissociation that might take a little more time than we have to explain the difference there. But you asked why MDMA would be better, why I think it's better. So MDMA is really, it's just so well suited to minimizing the physiological effects of PTSD while also increasing our cognitive functioning in the prefrontal cortex. So being awake and alert for an 8-hour period, to be in this kind of optimal arousal zone, to have this intensive therapy process just seems to be a really successful way to get at trauma. Where with ketamine, the way it can look is there are ways to use ketamine-assisted therapy that looks a bit more like MDMA therapy, where we're using lower doses of ketamine that are not fully dissociative, but they can kind of round out some of the rough edges, help someone feel more relaxed and more calm, and have a little bit of separation from the intensity of the emotions that they normally feel. And that can allow someone to have a therapy session where they're able to access things that they're not normally able to access, or normally would be too challenging to talk about. So it can be really helpful in that context. But in the higher doses of ketamine, when we're getting into the psychedelic range, it causes profound psychedelic effects of people having out-of-body experiences, going through different dimensions, going through space, many different things that people experience that are often felt as beautiful and profound. But it is kind of like someone is a little bit more on their own in there, where they might find their trauma or they might not. So there is some room going there if someone is properly prepared to go into that deeper process and try and do trauma work and have the proper support of a therapist in that process. But I would just say it just takes more preparation and the right kind of person to take that direction.
Thank you.
Cool. Are there any more questions from the group? If not,
I have a quick question if nobody else does.
yeah, of course, go for it.
So I'm not sure how like the process is with like medical grade MDMA or what it's made from, but I know that like street MDMA is produced from a rare tree in Cambodia in Southeast Asia, which is going extinct because of street MDMA use. Is there like how is it made? Does it use the same tree when it's made medical grade?
Thank you. Yeah, so MDMA is now divorced from the saffron oil tree. So it's not needed anymore in the production of MDMA. So there's actually a really good mini doc that was done, I think in the last month or two, even, that might have been a Vice doc on the war on drugs, but one of them is specifically looking into MDMA and the saffron oil tree and the rise and fall of MDMA production when actually governments around the world tried to shut down MDMA production by burning down the fields of those trees. So it was not actually necessarily MDMA that was producing the issues with that tree going extinct, but that there was a widespread effort to burn down forests of those trees to interrupt MDMA production. And so there was a period for a number of years in the late 2000s where MDMA had gone down dramatically after this effort had happened. MDMA became way more expensive and way harder to find. But in that time, that's where these other MDMA stand-ins became more popular. And so we actually saw way more deaths and way more issues in that time frame, that people were taking what they thought was MDMA, but were actually cathinones a lot of the time. So there's some thought that effort to block MDMA led to these unneeded deaths as these other compounds flooded into the market. But over the last maybe 8 years, a new method for producing MDMA was developed, which has led to it not being tied to the tree, and it's cheaper and more easily accessible to produce.
Yeah, that's really interesting, and it has a lot of implications for the purity of street MDMA, especially moving into the future. I also know that the U.S. government did the same thing or they tried to do the same thing with the cocoa leaves.
Mm-hmm. Right. Yeah, it is one of the reasons, suspected to be one of the reasons, this change of why purity and quantity of MDMA has increased over the last number of years, to why it's not uncommon to get a 500 milligram ecstasy pill, because it's just so much more affordable to produce.
Thank you.
Okay, another question. I know we only have like 7 minutes left, but the question is from Sheer, and has any work been done on MDMA and healthy controls?
Yes. there is a part of the phase 2 clinical trials and phase 3 clinical trials that MAPS is working on is actually a healthy controls version of the study that was really being done with therapists in training. And so the way they were doing that was that as you're a therapist going through training to be an MDMA therapist, part of that program could be to actually have your own MDMA therapy take place. And so there's some benefits to that. You know, there's the belief in the psychedelic therapy world that it is really useful to have experience with the substances that you're going to be working with, so that you actually know what it's like to be on the couch. You actually know what it's like to have that medicine come up, what you're going to be feeling, what it's going to be like to talking about things while you're on the medicine. So there was actually this side part of the study with healthy participants who are the therapists going through the training program. So that's kind of how they worked around doing the healthy participant study. And then there's also, I believe, a study that was coming up. I think it was going to be at UCSF, if it hasn't started already. But they were going to do, I think, a pharmacokinetics study looking at people taking high-fat diet before taking MDMA versus, I believe, either low-fat diet or fasting before taking MDMA. So that was one study that was going to be with healthy participants.
Cool. Cool. I think that's all the chat questions.
I can note if do we have a minute?
Yeah, go for it.
Just in addition to that question about healthy participants, one interesting thing that's happening, because I think we all have, or many of us have the understanding that these can be helpful for healthy people. You know, we've talked about the betterment of the healthy person, that psychedelics can help us to develop and change and see things differently. That it's not just for treating severe mental health issues. And the first major clinical trial or clinical study that's been done was another study that I'm actually working on, doing a qualitative study. It's a Johns Hopkins and NYU study with psilocybin, where the participants are religious professionals. So they're healthy subjects, but they're leaders of different different religious groups. So they've all gotten psilocybin through a similar protocol as the other psilocybin studies. And right now we're going through the interviews of them, and it's incredible. So keep an eye out for that coming up.
Cool. Thank you. Yeah, and I think that in the last 3 minutes, maybe as just a way to wrap up, for students that may be interested in continuing work in this field, what do you see as exciting opportunities or places to contribute, and yeah.
You know, something that I've done is try and do as much mentoring and connecting with students who are interested in getting into this work as I can. So at this point, you know, trying to find other people who are interested in this work, getting connected, getting mentorship from someone who's in the field, joining a psychedelics club, like the Psychedelics Club here at UC Berkeley would be a great step to really get connected with other people in the field and find projects to work on. I mean, one of the great things about being a student is having that opportunity to join projects, to, you know, find the time to take part and volunteer in these things however you can. So I know really how I started was just volunteering at every psychedelic therapy event that I could find of going and taking tickets at the door or whatever, and then slowly built up to being an intern at the MAPS office and doing my dissertation on MDMA and working with the Zendo project. These things just came slowly from just trying to reach out and do as many things in the community as I could. And qualitative research is actually kind of uniquely positioned for students to set up and benefit from. So it's a really decent option for somebody doing a master's project, a thesis, or a senior project rather, dissertation, whatever. Is there are options potentially to do qualitative studies. I'm actually working with someone at UC Berkeley now who's doing a qualitative study on one of our MDMA studies. So it's definitely possible to do.